Welcome to our video on sodium disorders. After watching this video on sodium disorders, you should be able to discuss the differential diagnosis of hypo and hypernatremia. You should also be able to diagnose the underlying etiology of hypo and hypernatremia based on urine osmolality and volume status, and be able to provide management plans for both hypo and hypernatremia. In part 1, we will be discussing hyponatremia, defined as having serum sodium concentrations less than 135 millimoles per liter. The normal range is 135 to 140 millimoles per liter. Hyponatremia is the most common electrolyte abnormality in the hospitalized setting, particularly in the intensive care unit or ICU. It is an independent predictor of death among ICU and geriatric patients and patients with heart failure, myocardial infarction, and cirrhosis. Besides its association with having worse survival in different clinical settings, patients with hyponatremia can have poor mentation and increased risk of falls and fractures. Severe cases of hyponatremia can be life-threatening. Before diagnosing the underlying etiology of hyponatremia, we need to first rule out pseudo-hyponatremia. It should be mentioned that some old laboratories may falsely measure serum sodium as low when its true value in the plasma is within normal range. When this occurs, it is called pseudo-hyponatremia. Conditions that may interfere with the accurate measurement of serum sodium concentration include paraproteinemia or severe hyperlipidemia. To determine if technical measurement errors are possible, check with your institutional laboratory staff. Another form of hyponatremia that does not need investigation is when it is associated with transient extracellular water shift. In the presence of hyperosmotic agents in the plasma, such as high blood glucose or high dose of mannitol or sucrose, intracellular water shifts out into the extracellular space, expands the extracellular water volume, thereby lowering plasma sodium concentration. In the case of hyperglycemia, cellular uptake of glucose with the administration of insulin will shift water back into the cells and correct the hyponatremia. There are many causes of hyponatremia. To best derive at the correct diagnosis, we rely on a systematic approach. In addition to obtaining a good medical history, we assess the patient's urine osmolality and volume status. A concentrated urine, that is, a urine with a high osmolality generally greater than 150 plus or minus 50 milliosmoles per kg, generally indicates the presence of ADH. This is because ADH promotes renal water reabsorption, thereby producing a concentrated urine. Next, we categorize the ADH state as being appropriate, inappropriate, or dysregulated based on the patient's volume status. Hyponatremia associated with a high urine osmolality and clinical evidence of hypovolemia is referred to as hypovolemic hyponatremia. The high ADH state in hypovolemic hyponatremia is considered appropriate because ADH is secreted as expected in response to hypovolemia. Conditions where patients may present with hypovolemic hyponatremia include any type of bodily fluid loss, third spacing, the use of diuretics, particularly thiazide diuretics, mineralocorticoid insufficiency, and renal or cerebral salt wasting. Hyponatremia presenting with a high urine osmolality and hypervolemia associated with a low effective circulating volume is referred to as hypervolemic hyponatremia. Conditions that may present as hypervolemic hyponatremia include cirrhosis, nephrosis, and heart failure. Although patients in this category are volume overloaded, their fluid does not effectively circulate in the body, but leaks out into the interstitial space and body cavities. It is the low effective circulating volume that drives ADH secretion in these patients. Since ADH secretion occurs secondary to a diseased state that can only be shut off with the cure of the primary disease, ADH release in this category is referred to as dysregulated ADH. When patients present with a high urine osmolality and normal volume status, the syndrome of inappropriate ADH release, commonly referred to as SIADH, may be considered. SIADH refers to conditions where ADH release occurs independently of hypovolemia or hyperosmolality. SIADH itself has a long list of underlying etiologies. In general, just remember the big categories that are associated with SIADH. These include malignancies, pulmonary disorders, pathologies involving the central nervous system such as brain infections, brain trauma, or tumors, neuropsychiatric medications including antipsychotics, antidepressants, antiepileptics, narcotics, nausea, vomiting, and pain. How does a high ADH state cause hyponatremia? Recall ADH upregulates the expression of water channels called aquaporins in collecting tubules for increased water reabsorption. Figuratively, ADH turns the kidneys into a big dry sponge that will reabsorb any water they are given. Hyponatremia occurs when water is given. Having ADH alone without free water intake cannot cause hyponatremia. In fact, individuals who are lost in the desert without water, their hypovolemic state may increase ADH release, but without water, these individuals will never develop hyponatremia. On the contrary, the continuing hypotonic sweat loss in these individuals will eventually lead to the development of hypernatremia. It is the combination of a high ADH state plus free water intake that causes hyponatremia. Now getting back to conditions that present with inappropriate ADH release in euvolemic patients. Other than SIADH, other conditions include low thyroid function or hypothyroidism and cortisol insufficiency. Finally, patients with a condition called nephrogenic syndrome of inappropriate antidiuresis, commonly abbreviated as nephrogenic SIAD. Nephrogenic SIAD is a condition where there is a gain of function mutation of the ADH receptors, also known as vasopressin V2 receptors. In this condition, no ADH secretion is needed to activate the receptors. The mutated vasopressin receptors are produced in their activated form. Clinically, patients present similarly as those with the syndrome of inappropriate ADH release. When volume status is difficult to assess, we can also rely on urine sodium concentration. In patients with hypovolemia or hypervolemia, but low effective circulating volume, the kidneys will try to hold on as much sodium for the body as possible For this reason, the urine sodium concentration is typically low or less than 20 millimoles per liter. Exceptions in the hypovolemic state include those conditions where the hypovolemia is due to ongoing renal sodium wasting. In these conditions, urine sodium concentration can be high and much greater than 20 millimoles per liter. In euvolemic hyponatremia, the kidneys don't care about holding on to sodium. For this reason, urine sodium concentration basically reflects dietary sodium intake and is typically greater than 30 to 40 millimoles per liter. Let's now shift our focus on hyponatremic conditions that present with a dilute urine where the osmolality is less than 150 plus or minus 50 milliosmoles per liter. The differential diagnosis here includes polydipsia, where patients drink water excessively that overwhelms the kidney's free water excretion capacity. The retained water leads to hyponatremia. Tea and toast and beer podomania refer to hyponatremia that occurs when patients eat very little relative to free water intake or alcohol ingestion in the case of beer podomania. The low dietary solute load delivered to the collecting tubules does not provide a sufficient osmotic pool to prevent water from getting reabsorbed. The excess free water reabsorption leads to hyponatremia. There are other hyponatremic conditions that are considered normal for the affected individuals. Mild hyponatremia is expected in normal pregnancy. This is because the threshold for thirst and ADH release is lowered in pregnancy. Some individuals may have been born to live well at a lower level of plasma osmolality or sodium compared with that of the general population. Others may have had hypothalamic injury for whatever reason and have a so-called reset osmostat. In both pregnancy and reset osmostat, patients can still concentrate or dilute their urine as needed. They just normally live at a lower plasma sodium concentration compared with that of the general population. Finally, in patients with kidney failure, the kidneys can no longer adjust their urine osmolality based on the body's need for water. In this case, the urine typically remains relatively isotonic to the plasma regardless of volume status. The urine osmolality is more or less around 300 milliosmoles per kg. Patients with kidney failure can easily develop hyponatremia when they ingest any little excess amount of water. Why do we care about hyponatremia? Patients with hyponatremia can present with a multitude of symptoms and problems. Symptoms associated with hyponatremia depend on the severity and acuity of the hyponatremia. Patients with chronic mild hyponatremia with serum sodium concentration in the range between 125 and 135 millimoles per liter may be asymptomatic. Patients with moderate hyponatremia or having sodium less than 125 can present with symptoms such as headaches, disorientation, lethargy, nausea, vomiting, depressed reflexes, falls, muscle cramps, and restlessness. In severe cases of hyponatremia, patients may present with seizures, respiratory arrest, coma, permanent brain damage, severe brain edema, brainstem herniation, and death. We've learned that moderate to severe hyponatremia can be detrimental to patients, so we should definitely correct the problem. A caveat, however, is that rapid correction of hyponatremia can lead to rapid brain cell shrinkage, which could also present a serious neurological problem. Brain cell shrinkage that occurs as a result of rapid correction of hyponatremia can lead to a condition called osmotic demyelination syndrome, or ODS. ODS may be evident as low attenuation lesions on unenhanced brain CT or hyperintense lesions on MRI. Imaging findings of ODS typically lag behind clinical symptoms. Routine images acquired within 1 to 2 weeks after the onset of symptoms may be negative. Slow correction of hyponatremia allows brain cells to accumulate and generate new intracellular organic solutes to match the extracellular increase in osmolality, thereby preventing rapid osmotic water shift and changes in brain cell volume. How does ODS manifest clinically? After the rapid correction of hyponatremia, patients will have improved mental status for a couple of days, only to rapidly deteriorate days later. Symptoms include behavioral changes, dysarthria, dysphagia, flaccid paralysis that later becomes spastic paralysis, and possibly locked-in syndrome, where patients are aware of their surroundings but cannot move or communicate verbally due to complete paralysis of nearly all voluntary muscles in the body, except for eye movements and blinking. Depending on the severity of ODS, patients may or may not recover. It is therefore critical to closely monitor hyponatremia correction rates. In addition, pay special attention to patients who may have higher risk of developing ODS. These include patients with severe hyponatremia, malnutrition, alcoholism, hypokalemia, liver failure, and organ transplantation. How fast can we correct hyponatremia? In severe hyponatremia, when patients present with seizures and/or coma, rapid correction with hypertonic saline is indicated. The rate of correction may be as fast as 2 millimoles per liter per hour for 2 to 3 hours, or a total of 4 to 6 millimoles per liter within 2 to 3 hours. It has been suggested that a 5% increase in the serum sodium concentration can substantially reduce cerebral edema. Even seizures can be corrected by an increase in serum sodium concentration of 3 to 5 millimoles per liter. For patients who present with hyponatremia occurring within less than 24 to 48 hours, there is no need for correction rate restriction. For patients who develop hyponatremia over 48 hours or greater, or of unknown duration, the correction rate should be restricted to 4 to 8 millimoles per liter per day. A lower target range of 4 to 6 millimoles per liter per day may be used in patients with high ODS risk. As a reminder, high ODS risks include severe hyponatremia with serum sodium concentration typically less than 105 millimoles per liter, alcoholism, malnutrition, advanced liver disease, and hypokalemia. What options do we have to treat hyponatremia? We can give patients salt, whether it be intravenously or oral form, restrict water intake, increase food intake to increase the filtered solute load that can act as an osmotic pool for greater water excretion, induce renal free water excretion, and of course, treat the underlying condition or cause whenever possible. Increasing water excretion by the kidneys may be done by blocking the action of ADH with a class of medications called vaptans. Vaptans act by binding to vasopressin B2 receptors, thereby blocking ADH binding and its downstream effects on aquaporin-2 expression. The lowered aquaporin-2 expression leads to reduced water reabsorption, thus effectively induces free water excretion. For this reason, vaptans are also called aquaretics. Because vaptans block the action of ADH on water reabsorption, this class of medication is used for hyponatremia associated with inappropriate or dysregulated ADH states. The two conditions approved for use of vaptans include heart failure and syndrome of inappropriate ADH release. Vaptans are contraindicated in patients with hypovolemic hyponatremia because the increased ADH in hypovolemic hyponatremia is appropriate. Treatment for these patients is volume repletion, not blocking ADH with vaptans. Although patients with liver disease and cirrhosis have dysregulated ADH and theoretically would benefit from the use of vaptans, their use should be avoided due to potential liver toxicity associated with the drug. It should be noted that overly rapid correction of plasma sodium concentration leading to the development of osmotic demyelination syndrome has been reported with vaptans. Close monitoring for the rate of sodium correction during vaptan treatment is warranted. Examples of vaptans include conivaptan, tolvaptan. Note that generally, vaptans are only used for refractory cases of hyponatremia associated with heart failure or SIADH. Now that we have discussed the different therapeutic options for hyponatremia, how do we select the best treatment options for our patients? Let's go back to our figure with the differential diagnosis. Whenever possible, treat the underlying condition or remove the source that led to the hyponatremia in the first place. For hypovolemic hyponatremia, replace the fluid loss with fluids. For euvolemic, hypervolemic hyponatremia, and kidney failure associated hyponatremia, restrict free water intake. Advise patients to only drink per thirst. Avoid drinking excessively. Vaptans may be considered to treat hyponatremia associated with heart failure or SIADH if source removal and conservative therapy do not correct the hyponatremia. For polydipsic patients, educate the need to curb excessive water intake. For patients with low dietary solute intake, advise patients to eat more. For pregnancy-associated hyponatremia, do nothing. This is a normal physiological response. Note, however, pregnancy-associated hyponatremia is typically mild and ranges between 130 to 135 millimoles per liter. More severe hyponatremia would be abnormal. Evaluation and treatment would then be indicated. For reset osmostat, treat the underlying cause if this is acquired and treatable. Although the treatment plans for hyponatremia seem relatively straightforward, a few potential problems may arise during the treatment of hyponatremia. Caution with strict water restriction in patients with chronic polydipsia. Patients with chronic polydipsia have a washed-out medulla. The chronic exposure to high volume of water interferes with the maintenance of the medullary concentration gradient that is necessary for effective water reabsorption. This leads to poor water reabsorption by the kidneys. Additionally, the hyponatremic state resulting from polydipsia may suppress ADH release. This also adds to poor water reabsorption. What this means is, in polydipsic patients, the kidneys are conditioned to maximally excrete water. When these patients are abruptly deprived of water intake, rapid correction of hyponatremia easily occurs because the kidneys will continue to pour out high volume of a dilute urine. Acute strict water restriction is therefore not advisable. It is more prudent to gradually reduce free water intake while increasing solute intake to allow the rebuild of the medullary concentration gradient. In the case of overly rapid correction during water restriction, consult nephrology immediately for back correction. Beware that ADH secretion may be acutely shut off in patients with any form of ADH-dependent hyponatremia, whose underlying reason for ADH release has been treated. For example, if a hypovolemic patient is given a large volume of normal saline rapidly as a bolus infusion, the rapid volume expansion can acutely shut off ADH release. Without ADH, a rapid aquaretic phase can occur. This would then lead to overly rapid correction of hyponatremia. For this reason, it is vital to monitor urine output closely during the treatment of hyponatremia. In patients with SIDH, the use of any fluid with a tonicity that is lower than that of the urine may lead to increased water reabsorption and worsen the existing hyponatremia. This is because patients with SIDH have a great water resorptive capacity. The urine osmolality is an indicator of how much the kidneys can concentrate any fluid that passes through. The rule of thumb is to only give fluids with a higher tonicity than that of the urine if fluids are needed in a patient with hyponatremia due to SIDH. When patients with hyponatremia need potassium replacement for hypokalemia, it is very important to know that any potassium supplement is equivalent to sodium administration. This means potassium supplementation can indirectly increase serum sodium concentration. This is a cartoon representing intracellular and extracellular space, where the extracellular space consists of interstitial and intravascular space. Remember, potassium is an effective solute and is predominantly an intracellular cation. When a patient is given potassium supplement, potassium will enter the cells. This leads to either an extracellular shift of sodium, which would increase the extracellular sodium concentration, or intracellular water shift along with potassium. The loss of extracellular water in the second scenario can also increase the extracellular sodium concentration. For these reasons, be aware that the administration of potassium can increase serum sodium concentration exactly as if the patient was given the same amount of sodium. This is our to-do list when there is a patient with hyponatremia. First, verify that the serum sodium concentration was measured correctly. Diagnostic considerations: assess the patient's volume status and obtain urine osmolality and sodium. Other tests that may be helpful in the diagnosis of hyponatremia include uric acid. This is typically low in patients with SIDH, but high in patients with hypovolemia. because uric acid reabsorption is increased in the hypovolemic state. Morning cortisol and thyroid function may be checked to rule out hypocortisolism and hypothyroidism respectively in patients with evidence of increased ADH state. Patients who do not eat well tend to have very low blood urea nitrogen or BUN. We can look at BUN as a clue to poor solute intake. Finally, it has been suggested that hyponatremic patients who have concurrent hypokalemia, hypophosphatemia, and/or hypomagnesemia may have an increased risk of ODS. Because of this, these electrolytes should also be monitored. In terms of therapeutic considerations, recall our therapeutic options include salt supplement, water restriction, or renal water excretion. The latter can be achieved by increasing solute intake and/or the use of baptans. The use of baptans is restricted for patients with heart failure or SIDH. Potential problems that may arise should also be kept in mind. These include intravenous fluid tonicity selection in patients with severe SIDH to avoid worsening of hyponatremia, potentially overly rapid correction of hyponatremia that may occur with potassium supplementation, and high urine output state when patients' ADH secretion is abruptly shut off. Abrupt ADH shutoff may occur with rapid volume expansion in hypovolemic patients or treatment of the underlying condition that induced SIDH. Let's now switch gear to hypernatremia. Hypernatremia is defined as having serum sodium concentration greater than 145 millimoles per liter. How do patients with hypernatremia present? In hypernatremia, water shifts out of cells and causes cell shrinkage. Neurologically, patients can present with muscle weakness, irritability, restlessness, and in severe cases, confusion, seizures, coma, and death. Similar to hyponatremia, symptom severity depends on the severity and acuity of the hypernatremia. Similar to hyponatremia, we can categorize the differential diagnosis of hypernatremia based on urine osmolality and volume status. For patients who present with hypernatremia and a dilute urine, that is, a urine with an osmolality less than 2 to 300 milliosmoles per kg, it is most likely that the hypernatremia results from excessive free water loss. This can be seen in conditions such as central or nephrogenic diabetes insipidus. Rarely, this may be seen in pregnant women where placentas overproduce vasopressinase, an enzyme that degrades ADH and renders it inactive. This condition can be easily managed with the administration of DDAVP or delivery of the baby and placenta. When the urine osmolality is high, that is greater than 300 milliosmoles per kg in the setting of hypernatremia, we can look to the patient's volume status for further clues. In the case of hypovolemia, hypernatremia can occur when there is severely low water intake. This may be due to the lack of access to water, which is most commonly seen in bedridden patients or patients with hypothalamic injury and associated thirst defect. Hypernatremia can also occur when there is excessive free water loss with osmotic diuresis or hypotonic bodily fluid loss, such as excessive sweating without appropriate free water replacement. In the case of euvolemia or hypervolemia, we can consider hypernatremia due to transient intracellular water shift in conditions with increased intracellular catabolism, such as rhabdomyolysis or seizures. Hypernatremia is typically only mild in these conditions. Excessive sodium relative to water intake may also lead to hypernatremia. Examples include nasogastric tube feeding without adequate water supplement, or the infusion of fluids with higher sodium content relative to hypotonic bodily fluid loss. How do we treat hypernatremia? Correction rates for hypernatremia are dependent on the acuity and severity of symptoms and are similar to those used for the treatment of hyponatremia to minimize rapid changes in brain cell volume. Similar to the management of hyponatremia, the underlying etiology of hypernatremia needs to be treated whenever applicable. For example, if water is lost due to osmotic diuresis from hyperglycemia in patients with uncontrolled diabetes mellitus, provide insulin. In patients with central diabetes insipidus, provide DDAVP, the synthetic analog of vasopressin. For nephrogenic diabetes insipidus, a trial of thiazide diuretic may be considered. Thiazides are thought to induce a relative hypovolemic state, which enhances avid sodium and water reabsorption at proximal nephron segments, thereby limiting the amount of water delivered distally to be excreted into the urine. For pregnant women with overproduction of vasopressinase from placenta, support with DDAVP until safe delivery of the baby. The problem will resolve following delivery of the baby and the placenta. Of course, in the meantime, all patients should receive free water to correct the present hypernatremia. Fluid selection depends on hemodynamic stability and the degree of salt and water loss. This table is for your reference for use during your clinical years. Normal saline is relatively isotonic to plasma. It is the best fluid to use to rapidly expand patients' volume when there is hemodynamic instability or collapse. Of note, patients with hypernatremia and hemodynamic instability tend to have serum sodium concentration much greater than that of normal saline. The use of normal saline, therefore, can still lower patients' serum sodium. Half normal saline or 5% quarter normal saline may be used in patients who need both sodium and water replacement. 5% dextrose water may be used for patients who only need free water replacement. Note that dextrose is completely metabolized by the liver. Infusing D5 water is equivalent to infusing free water. The 5% dextrose is added to make the infused water or quarter normal saline relatively isotonic to plasma. Infusing free water or quarter normal saline alone causes severe red blood cell swelling and hemolysis and should never be used. At this time, you should be able to discuss the differential diagnosis of hypo and hypernatremia. You should also be able to diagnose the underlying etiology of hypo and hypernatremia based on urine osmolality and volume status, and be able to provide management plans for hypo and hypernatremia. The end.